December 10th, and we are ready for another CCO Live. If this is a new event for you, if you've never gone to one of our CCO Lives before, it's really different compared to the other things that we offer. And I really enjoy them because they're casual. Thus, I have my flamingo shirt on. Barb is our guest tonight, an expert in several different topics. She's a prolific writer and will mention a blog article that she just sent out recently that's real applicable to the changes that are being made in the new year. So let's welcome Barb. Hello, Barb.
Hi, Alyssa. How you doing?
I'm good. So, Barb and I met, I think, for the first time at one of the conferences. Her and Laureen have known each other for a very long time. And so we were introduced by Laureen when we got to go to a conference together. And then we always meet up at conferences. I don't know if we have ever met face to face outside of the networking of the conferences, but we do. We're both on a group where we instant message and talk about stuff. So I wouldn't say that I talk to Barb daily because I don't. However, I have access to her daily through that. And I would say at least once a week, we're in there chatting about whatever new stuff is happening. I also wanted to just do a little quick shout out about Barb's credentials. Maybe real quick, can you explain what we know what the CPC is, the COC, the CPC-P, the CPC-I, because she's an instructor, but for some people, they may not be familiar with those other three credentials that the CPCO, can you tell them about that one, the CENTC and the CMCS real quick?
Okay, the CPCO is a Certified Professional Compliance Officer, which means I know a lot about compliance and I do a lot with compliance. As a matter of fact, one of my favorite activities is I do expert witness work. I help practices who get in trouble, or I help practices when they're in civil lawsuits. So that's less in trouble. Lots of times they may be defending themselves or they may be going after somebody else. And so I do expert witness work. The reason I'm good at that is my background before I ever got into the coding area is I'm an industrial engineer with an MBA. And so I'm very good in analytics. And so I do a lot of expert witness work, and I like that. But I help practices when they have problems with payers or they have problems with regulatory authorities, whether it be from an insurance company or, in the worst case, the assistant U.S. attorney is going after them for fraud. I've helped defend them as part of the team. And it's not just me that makes a difference. It's me and other people who are on the team that help the practices.
And that's exciting stuff because we were just talking before that, everybody knows I love the ICD. We're going to give you a little heads up about some codes at the end. But Barb would be a specialist with CPT codes, and HCPCS codes because of just what she was talking about. Those are really relevant. Okay.
I concentrate less on ICD-10. I know enough to code an ICD-10.
Right.
But I'm not an ICD-10 coder that would go after CIC.
Right.
Because, and I have friends that I go to when I get into questions like, what would the right ordering or where is the guidance for how this would be used. I have you. I'm very good friends with Sherry Poe Bernard, who wrote the book on HCC coding.
Oh, yeah.
So I have colleagues, Donna Malone, who I go to in those areas because I know what I know and I know what I don't know. And
that's key.
I go to my colleagues. I'm a big networker. I was actually Networker of the Year.
Save that because we're going to talk about that.
Okay.
She's jumping the gun because I told her what I was going to ask her ahead of time. Tell them about the CENTC.
The CENTC is actually now a defunct credential. You can't get it anymore, but if you have it, you get to keep it, which is a certified ENT coder. And the reason they stopped offering it is not enough people were taking the exam, so they didn't think it was worth maintaining it. and it's a shame because I know a lot of people in the field of otolaryngology who would like
Yeah.
to take that certification. I probably know about 20 to 25 people who want to take that certification who are experts in ENT, but AAPC no longer offers it. But
You know,
upright
that's really interesting because I did a little stint with some ENT specialists, and then there was one particular that I talked to recently. All she did was work on vocal cords. She was an extreme specialist, and and we forget all of the things that can happen to one little tiny part
yeah.
of the body. So yeah, that's a really
and ENT covers a lot of areas.
yeah.
You're talking about your throat, you're talking about everything in the mouth, you're talking about your nose, which covers your maxilla and all of this area here, over to your ears and everything in your ears, plus your skull, and it gets into things, and then your face. I mean, the areas that and the CPT codes that are covered within ENT is huge, starting with into integrity codes, going into respiratory codes, going into digestive codes, because you get down into the throat and things like that.
Yeah.
So now we're in the 40,000. We get to skip the 50,000 codes, which are like the genitourinary codes.
Right.
We have codes in the 60,000 codes for the thyroid, and then the ear. And then
that's
there are codes in the 90,000, which are ENT specific codes for audiology and allergy and ENT testing and things like that. So there's a huge range of codes that ENT covers.
That's right. Okay, tell us about the CMCS.
Then the CMCS is actually a certification from the American Medical Billing Association. They started with the CMRS, which is a certified medical reimbursement specialist, and then they started offering the CMCS, which is a certified medical coding specialist.
Right.
So took that exam. That exam is offered totally online, and you take the test, and they grade it instantaneously, and you get feedback, within a few minutes whether you've passed the test.
One of the things I heard about this, which I'm a big fan of that particular organization, and man, if you want to know anything about billing or connect with really smart billers that are real world orientated, that's the organization to go to. And that is exactly what I hear about that exam, that it's a very practical, real world exam. If you can't do what's needed for that exam, then you can't make it in the real world.
Yeah, and AMBA people are very real life, practical medical billing people. The members are people who own their own billing companies.
Right.
My own billing company for 14 and a half years. So, they're my people.
They're your peeps. Let's get into our first question. Now, I let her know that we're only going to talk about three things because Barb and I both are talkers, and plus we love what we do. So we're pretty passionate about what we do. And so I had to kind of narrow it down to three things that I knew she could really offer great advice to you guys. And again, this is like a casual thing. Laureen's always saying kibitz. I don't know where that comes from, but anyway, we, just our casual thoughts, about these particular topics. And I know that Barb is bombarded with the changes because this is her specialty, and then going into the new year. So what I wanted to have her share with you is, the thought process, and everything is changing. That has changed into 2020 for the way we're practicing medicine, and the telehealth, first of all, it's been around for a very long time, and but it was just not really implemented or utilized that much because, one, there really wasn't that much of a need for it. Two, nobody really understood how it worked and how they were going to get reimbursed, right? And And so it's like moving into the new age. I think COVID has pushed us in to our capabilities with the IT and all of this stuff that we had available to us. So, what are your thoughts, Barb, as far as people in coding and billing, that particular bubble of medicine that they need to be ready for?
The telehealth, actually, people weren't using it because it was actually designed to be used for rural healthcare and federal qualified healthcare centers.
I know they used it at penitentiaries in Texas. They were like a pilot program.
Yeah, but it was not designed to be used for your everyday practices in that we worked in. Unless you were in rural healthcare or FQHCs, you're not allowed to use telehealth. It wasn't within our purview, and that rule is encoded in the law, and so we needed those waivers. That I have to compliment CMS for getting those waivers produced so quickly in March and April for us to be able to change the way we practice medicine. They really just zipped them out. And one of the reasons I became an expert in telehealth in March and April is my work fell off. Nobody needed me. I actually had a bunch of things where I was supposed to travel to various venues to do work as a consultant, and they all just got canceled, which I was glad.
Right.
As of March 13th, I started isolating. And so I had nothing to do. And so I just stayed on top of everything that was coming out of CMS. And as the state came out of CMS, I stayed as an expert reading every word that was coming out of all of these rules, proposed rules. They basically were all proposed rules with comment, and none of them ended up being a final rule. And these new rules with the waivers gave us permission to do telehealth everywhere. It also, telehealth was limited where the patient, even when you're doing it, you couldn't do it from the patient's home. The way the law is, the patient had to go to something called an originating site.
Right.
Now, with COVID and the public health emergency, we can do it with the patient at home.
With their cell phone.
And the doctor at home, or the doctor at the country club, as long as they're like in a quiet place and nobody is listening. The doctor can do it anywhere. And the patient can do it anywhere. And so it all of a sudden gave us a lot more flexibility that we didn't have before. Right. And unfortunately, before, someone just told us before PHE, about 14,000 patients received Medicare telehealth services a week. But now I millions, I think, received, you may have that number, Skylar, received telehealth. And I'm one of the big users of telehealth because I was isolating. I have complicating factors. And so I didn't want to go out to the doctors. I was doing telehealth myself as long as I had something that the doctor didn't have to. All right. During the PHE, 12.8 million patients received Medicare telehealth from mid-March through mid-September.
And that's just Medicare, because personally, I think I used telehealth 4 times during this whole event. And one was for my son to the neurologist. So, that's...
And I had it. I used it. I had Blue Cross Blue Shield. So besides Medicare loosening up the rules, so did each of the payers. What made it difficult, though, was each of the payers had slightly different rules than Medicare. What I really liked was, I was surprised about this, the American Health Insurance Plan's website actually had a COVID website that listed all of the private insurances and what their rule, a slight little blurb about their rules with a link to each of the different private insurers that you could go to get their rules. So whenever I answered questions to people and they said, well, how do I do it for private insurers? I said, well, I can't tell you every insurer because everyone's different, but go to this AHIP website, and I would give it to them. I said, you're going to find all your answers there.
And just real quick, that's one of the questions that I'm going to ask Barb here in a little bit about some of the go-to resources that she has. And I wanted you to know that our club members will get all of her resources. We'll put those up with this slide deck again, one of the perks of being a club member is that you get this slide deck, you get the recording, you get a transcript and everything about what we've talked about. But all those resources that she's going to be telling us, we'll have those for our club members.
So I wrote quite a few blogs during from like March through August, and the reason I had to keep writing new blogs is that the rules were as Medicare moved fast, but because it moved fast, they had to keep changing things or adding more information to the rule because people needed more information. Also, Medicare was holding weekly office hour calls on Tuesdays at 5 o'clock Eastern time that I would get on along with my friend Don and Marie, and we'd all get on, and you'd have the opportunity to ask questions to Medicare to clarify things. It was wonderful. And now those calls are actually still being held, but they're every other week. They're not.
I heard you guys talking. I could see the conversation going, and I thought, I'm not getting in the middle of that because that's not my area. But I saw you guys really discussing those, and some of the stuff was, oh wow, that's great, and other was, oh, that's frustrating, and so
and
another.
And people didn't understand how to do things because, like, the rules for telehealth, for example, is telehealth has a place of service of O2. And what O2 does is it pays you the facility fee, not the non-facility fee when you use O2. But that's because the patient is going to an originating site, like usually it's a hospital, and the hospital is being paid for the facility. So that's and that's why the doctor doesn't get paid for their practice expense. But now that we were doing telehealth from our homes and we weren't using originating sites and Medicare wasn't paying for the facility fee to an originating site, Medicare says, we will pay for the practice expense. So you need to use place of service 11 so that you get paid your non-facility fee, your office fee, so that you get paid for practice expense. And people kept getting that wrong. And I had to keep saying it over and over again in all of the different groups that I hang out in because they were losing money when they were using the wrong place of service. That was a big thing.
I just saw a question come up that I wanted to address. I can see the chat. Gigi said, and this is a little bit off topic, but she said, should I do the CPC first or the CPCO? I think, number one, we'll have Barb put her 2 cents in, but you really need to know coding if you're going to be into compliance, and whether you get the certification or not. I am assuming, and again, that's not always the best thing to do, is that when somebody says, should I get this credential, that means you're going to take training for that credential and then get it, right? And so you need to be really good at coding, both the billing, have awareness of it, as well as you need to have an awareness of all the code sets. Let me put it that way. And then get the credential. Now you can go get the credential. You can sit for the compliance, and the compliance credential is a fabulous credential. It's on my wish list of next credentials to get. However, nobody's really going to give you that respect that you need unless they know you know coding, right? Because even though you're not really tested on a whole lot of coding issues, it's a big part of what you're going to be asked to do. The next thing I would just mention is that because we talked about AMBA, and they have a coding credential, which you can take online, you could get that credential and then go get the compliance credential. But again, that's with the understanding that you've had the training and you know, to be able to pass the test.
Yeah, a lot of it is your experience. See, in my day, you have to understand that I entered coding. I'm an old lady.
Did you have your coding codes out on the printout with the little holes? What was that called? You know, I remember that, but I can't remember what we called it. Yeah, the printout, and it would, you know, and then you'd have to pull all that paper off the edge and put them in books.
Yeah. Well, I entered the industry in 1990, and back then, when you went for a CPC, there weren't courses. There was an independent study course that you could buy, but nobody taught it. There was no such thing as a PMCC.
Yeah.
There was nobody teaching a course. What you did is you got experience, and then there was a study guide which you would look at, and then sometimes AAPC would have like a 1-day prep session, which actually I went to the Orlando conference in 1997, and they, instead of giving the test at the beginning of the conference, they gave the test at the end of the conference.
Yes.
And so
Yeah.
at the beginning of the conference, I sat in the 1-day prep class, and at the end of the conference, I took the test, but I never sat through a course. Lorene never sat through a course.
No.
She learned it all on her own. And
Yeah.
so back then, coders, and actually, you also already had to have your 2 years experience. There was no
Right.
such thing as a CPC-A. You had to have coding experience before you took the exam.
Or you couldn't pass the test, quite
Right.
frankly, if you didn't.
Right, exactly.
Jennifer said dot matrix. That was dot matrix, by the way.
Yeah, dot matrix printer. Yes.
Yeah.
Yeah, no such things. Or a laser printer was so expensive, nobody could afford that. But that was the old, and the paper was called green bar paper.
Yes, that's right. Green bar paper. You're right.
Yeah, those were the days.
I remember when
I ran my month-end reports for my doctors on that every month.
When I worked at the hospital, that's how long ago, because it was in the 80s. And the supervisor for the department, she'd been on both departments, and then they put her in the coding, but she also supervised transcription, but she said that's how we got our codes. They were printed off, they weren't in a nice pretty book, dot matrix, that green bar, and then we would put them all. Anyway, we're dating ourselves.
Yeah. But my point is that compliance is a lot of things. It's auditing, it's policies and procedures, it's billing,
education.
Education, it's HIPAA, which is privacy, security, code sets. So you have to know all of those stuff. So you sort of can't be coming in from the outside and really understand compliance. It's one of those things where you have to have done the job from the bottom up to understand compliance.
I agree completely. And it is an area that you even have to know, not just the business, but on the exam itself, you have to know HR stuff.
Yeah. Compliance and HR.
Yeah. So you really have to be well-rounded to set for that credential. And it is a great credential, a great goal, and a great career path too. So I would encourage anybody that's interested in it. I mean, I love it.
And you can do compliance before you have the credential.
Correct.
Just like I did coding before I had the credential. I actually do a lot of my business. I do auditing. I do not have an audit credential, and I'm really good at auditing. I just made a decision at this point in my life that I'm not sitting for any more tests. So I'm not going to take the auditing credential. And people hire me because I'm able to prove to them I have the experience and give good audit reports that I can do the job well. So keep in mind that as you become more and more experienced, the credential is just a verification that you know the material.
Right. That's correct.
Don't let not having a credential stop you from trying out for a job.
That's really good advice. I think that's excellent to state. Let's move on to our next question, which, hold on, I got to hit the right button there.
Do you want to at all talk about 2021 E&M on?
Yes, you know what? Let's go back. Let's mention that, because we were talking about that before we started, and let's give it a few minutes because it's so important. Go ahead.
So the way documentation and coding for 2021 E&Ms for outpatient and office services, only those codes, which is 99202 through 99215. None of the other E&Ms are changing, but just these codes are changing to a new method of determining the codes, and they're going to be based on medical decision making or time, and it's one or the other, which means if you decide to use medical decision making, time doesn't matter and you shouldn't document time. If you decide to make it time, there are going to be elements of medical decision making documented that because that's part of your assessment and plan, but then you have to put the information about time. So it's going to be one or the other, and it's going to be just for these codes. Now, keep in mind, even though we're calling it medical decision making for 2021 office and other outpatient codes is going to be a different way of calculating medical decision making than we did in the 95 and 97 guidelines. So what you're going to need to learn is, how is this medical decision making different, and how do you calculate it? And as well as, if you decide to use time, how is time used? The neat thing about time is it's face-to-face and non-face-to-face time on the date of service. Any time spent on a different date of service doesn't count. And I also recommend using medical decision-making as much as possible, because I believe that any doctor that's going to document a good assessment and plan is going to have higher levels of visit if they use medical decision-making. I also believe that doctors are going to put themselves into a time trap if they use time, because there's only so many hours a day they can work. And regulators who are going to be looking for fraudulent coders are going to be taking all the E&Ms that the physicians are submitting, multiplying them times the times, and saying, oh, this doctor doesn't work 16 hours a day, they must be fraud. And
you did not spend 20, you did not see each of your patients for an hour and saw 20 patients that day. There's no way.
They're going to come to those practices and audit them. And then when you're able to say, yeah, but I didn't use time, I used medical decision making, and see how this is a moderate level of medical decision making. And that's why it's a 99-214. It's not because it's the time related. They can't use time to prosecute you. And if you think about how many hours in a day and the number of patients you can see based on time, you will never be able to bill enough. So you really don't want to use time. You want to use medical decision making.
And this is where the ICD codes play a part, because they are what validate medical necessity. So if you code that a person's diabetic, but that's one thing. But if you code that your patient has a diabetic complication like polyneuropathy or, renal issues or something, then medical decision making goes up, right? So making sure the proper codes.
But you also, just using the ICD-10 is not enough in the new medical decision making. You have to show that you considered and it was part of your medical decision making. Because if you just mention that this patient has diabetes with polyneuropathy, and you don't mention how that impacts your treatment of that patient, that doesn't count. And if all you say is Dr. Smith is treating Mary's diabetes with polyneuropathy, that doesn't count. But if you say, my consideration of prescriptions that I'm prescribing are limited because of Mary's diabetes with polyneuropathy.
Bingo.
You can count that diabetes with polyneuropathy. And also what's neat is you can also count problems or complaints that don't have an ICD-10 assigned. So if the patient is making complaints and you're unable to find the definitive ICD-10 that goes with it, you're still searching, and you have to come to so in the current 95 and 97 guidelines, you're not allowed to count that. But now you're allowed to count those problems even though you don't have an ICD-10 for them, which is a very interesting. And so
that's huge. That's a big change.
And so what I'm telling doctors is you have to show your work. It's like when we did math problems in high school. You have to show your work. Also, if you considered a treatment plan that you decided not to do, that is a more radical treatment plan that you ended up going with something more conservative, you get credit in the table of risk for the treatment plan that you considered if you document it. So let's say
that's really cool. I had not thought about that. I'm going to write that down.
So if you have a patient who you are considering hospitalizing, let's say it's a patient with asthma and they're having complications, they have static asthmaticus and they have complications, and you're thinking, maybe I have to put this patient in the hospital, especially now with COVID. You say, well, you know what? I don't want to put you in the hospital. I'm going to prescribe the nebulizer meds. I want you to go home, and I actually want you to call me tomorrow 3 times during the day and tell me how you're doing, because I don't want to put you in the hospital. You get credit for that patient as hospitalization as part of the table of risk, even though you didn't hospitalize them. Or, for example, I'm finding in ENT, for example, the doctor wants to put me on Dymista. But now that I'm on Medicare and Part D, Dymista is not covered under the Part D prescription plans. And so the doctor says, although I'd like to put you on Dymista, I'm going to tell you to go to the drugstore and get over-the-counter Flonase Sensimist, which is an over-the-counter drug, because you don't have prescription coverage for Dymista. So under the 95 and 97 guidelines, that would fall under low for an over-the-counter treatment. But under this case, because the doctor wanted the Dymista, you get credit for prescription drug management, even though you didn't write a prescription, as long as that's what's written in the chart. So we have to tell our doctors, you're thinking all of this up in your head. You're having all these alternatives being calculated in your head. So what you now have to do is dump that in the chart. So even though we're putting less documentation for the history and the exam, we now have to put more documentation for the assessment and plan so that we show our work and we get credit for the things we considered and did not do.
Right.
I actually defended a neurosurgeon, a spinal surgeon, who the insurance company didn't want to pay him because he delayed surgery, putting the patients in PT because he didn't want to operate right away with patients with back pain. And by the 95 and 97 guidelines, he got credit only for low medical decision-making because of PT. Whereas in today's guidelines, he would get credit for surgery on the spine. And actually, surgery on the spine actually might fall under high.
Yeah.
If considering the surgery, but decided to do PT first, he would have gotten a higher credit of risk in that case. Now, you have to have either the nature of the presenting problems or data analyzed also to be higher to get a high level of medical decision making, because you need 2 out of 3, but at least you get your risk higher.
Right. I was just going to say, Lori made a good point. I saw it in the corner of my eye, that's true. And I like what Jane said about, also those forever diagnosis codes, which in my world are those chronic conditions that risk adjust, and for years I've been saying, you have to acknowledge those chronic conditions, because in your head, the fact that the patient has COPD is pertinent to their care when they have, some other issue going on, because it makes a difference on the medication that you give them, right? It makes a difference.
You have to say that. You can't just say the patient has COPD.
Right.
You have to say choices are
got to show the meat.
And so this is why, what doctors should be looking at with the assessment and plan on their EHRs is voice recognition, because now this is no templates with
or Scribes.
Or Scribes, but voice recognition or Scribes, instead of typing things, it's going to be free text of their thought process.
I love that. Yeah, you're right. That is probably an area, and this is for years we've been saying, people that want to get into our world, that if you have an IT background, that's a unique niche that you could get involved in, because there's always IT people. There's a lot of need for things just like that, not just the EMR that it used to be, but now it's also that higher level of.
There's a really neat practice that I did consulting and education for out in Erie, Pennsylvania, where they have 8 doctors and they only have 1 location. And they actually have their scribes in a back room in the office. And the doctors wear a Bluetooth speaker when they're seeing the patient. They have a large flat TV screen on the wall behind the patient. And so they're talking to the scribe who's not in the room while they're examining the patient and doing their assessment and plan. And as they're doing that, they see their EHR getting populated.
What,
by
and then so they can
scribes.
make a correction or something if
Right.
they say yes,
And the scribes who are experienced actually help them, because they'll say, "Oh, I see a little discharge in the ear," and the scribe will say, "Is it purulent, doctor?" And
yes.
I go, "No, it's not purulent," and the patient has no idea that they're talking to a scribe,
Well,
and the
but
scribe
the
populates
patient also gets to see the doctor's thought process. And so they say, oh, wait, how come he didn't give me an antibiotic? I think I need an antibiotic. And then, but the doctor is saying, this is a viral condition, da 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 da.
Yeah,
And so they're thinking, oh, because virus, isn't going to be an antibiotic isn't going to make a difference. Otherwise, the provider might not say that, or
and then
they're explaining it as they go along.
exactly.
That's
So
brilliant.
they're including the patient, but they don't have another person in the room with them. And then when the patient leaves, the doctor looks at the note, and then they sign right there on an iPad, and the note is done. They don't have to go back to their office and complete their notes.
I want to know more about this practice. I think this is amazing.
Yeah.
Where was it located at? What state?
They're in Pennsylvania, out in Erie.
Oh, cool.
And they are willing to actually, sell their technology and work on a consulting basis with other practices to put this in place.
Yeah.
They actually, they were saying they actually see there was like a closed Walmart in their town. They say we could see populating the whole Walmart with scribes for all the medical practices to be able to working with, because there's no reason for the scribe to have to be in the room.
Right.
And you don't have the scribe interfering in the patient-doctor relationship.
Yeah, you're right. Because
that
person standing there with the little portable, clicking everything, that just kind of makes some people uncomfortable, and so especially if you're talking about questions that are embarrassing, and so that's great.
Get in the way between the doctor and the patient.
Mm-hmm. I love that.
Not looking at a computer, but when they're looking at the patient who's sitting in the chair, they're also looking at the EHR that's flashing up on the large TV screen on the wall.
Yeah. That is great. And then the patient's looking at that too. And then they see, you know what I mean? They see how, well, it was kind of a game changer. I noticed that when people started getting their paperwork when they went home, used to, you just got to, these are the things you need to do. Here's your prescriptions. Now you actually get a copy of the report, and for a while, I think they were a little trepidatious because, nobody wants to read on the documentation that you're morbidly obese, right?
But you know what I am.
But that's what your BMI says, however, this really lets you see all the things that the provider discussed and covered. So, I loved it, but again, because I have people give me theirs. Hey, I went to the doctor. Do you want that paperwork? Yes, I do.
Well,
I'm going to turn you into an exam question.
It's interesting. United Healthcare just recently gave me, I didn't know they had it, gave me access to what they called my health record. And in it, over the years 2017 through 2019, it had all the diagnoses that had been submitted for me. And it also had all my meds and stuff like that. I'm going through it and I'm going, I wonder what doctor submitted this diagnosis. It doesn't make sense. I'm looking at this. I'm going, wait a minute.
I called, they printed out one for my son, the neurologist. He went to a specialist, and in his specialist for his actual type of epilepsy. And she handed me the paperwork, before we walked out, and it was our first visit. And I kind of flipped through it, and I immediately went to the ICD codes, and I said, well, there's a mistake on this diagnosis. And the nurse, who was an NP, looked at it, and she said, really? And I said, yes, because my son is intractable. He has, and it's a different epilepsy code. And I said, he picked the code for non-intractable, and we specifically discussed the fact that he's intractable.
Down menus, and he picked the first one.
Yeah, because the description of those epilepsy codes are like 3 sentences long, right. And so and intractable's like at the end. And so I said exactly as I think he just didn't see that was, but, and she said, well, I'll have him change that. And so they did. And she said, I don't have a copy of the new one. And I said, that's fine. And sure enough, I was able to go into his portal and they had changed it. But, being intractable and non-intractable is a huge difference, especially when you have frequent medication changes like he does, because one doesn't work. So he's intractable. That's why
your average person, first of all, doesn't know that.
Correct. Yeah. Yeah.
Okay.
Well, they knew what I did for a living too. So that's why she didn't balk and roll her eyes at me. She's like, oh, okay. So that's kind of fun.
I've gone to office visits, and I finished an office visit that is obviously a 99-213, no more. And then I go to the front desk and he checks off 99-214. I go, can I see the doctor a minute? And I talked to him about it. I say, did you really do? I said, does your documentation really show that? I
bet you're real fun. I'm going to tell you, you don't get paid as much because
I or they might do it the opposite. They'll give me a 99-213, and I thought it was a 14. I said, I'm giving you a little free consulting here.
Yeah, here. I did the exact same thing. I recently had pneumonia. And I had an asthma exacerbation from being exposed to some allergens that I normally don't get exposed to. And it ended up becoming pneumonia. And when I called to tell it was going to be a new provider, my provider had left. And I said, oh, he'll want to work me in. I'm at least a 214.
Well, I don't know if you can tell, I had a basal cell carcinoma taken out.
No, I can't tell.
And the doctor did an adjacent tissue flap on it. Mm-hmm. So I get the bill after the insurance paid, and they have it coded over 10 centimeters. And this thing is not even the size of a dime. And even with the secondary defect that they create, it's still no way it can be 10 square centimeters. So I call up the office because, first of all, I owe a lot for my 20%.
Yeah.
And it's the wrong code.
Right. That's right. And it does make a difference in the billing.
So I call up and she goes, the EHR codes it for the doctor. I go, oh, really? I said, do you know how the EHR codes it for the doctor? The doctor puts in the dimensions.
Yeah.
He put in the wrong dimensions, and therefore it came up with 14061, and it should have been 14060. This is the wrong code. So
and it's going to cost me money.
I said, you have two choices. You can resubmit a corrected claim to my insurance company, and I will pay the copay on 14060, or you can just write this off, which I'd rather you send a corrected claim because I'm a compliance person and I want my insurance to pay the proper amount. And if you don't do that, I will be contacting my insurance company.
Yeah.
I sent in a corrected claim.
Yeah. Okay, let's go to our next question. We've done so good with our time, but I know I'm a big networker. I know you are a big networker. So there's a lot of people that are just getting into the industry, and there's some people that have been out there for a long time, and they really don't know how beneficial networking is. What advice would you give people if they ask you about networking?
First of all, networking makes me look like I'm a genius in everything.
You're right.
I'm not. But if I need to know about ICD-10, I have people to go to like you.
Yeah.
And my friend Sherry Bernard.
Yeah.
Networking makes you look like you're way smarter than you are.
I like to tell people you're only as smart as the people you surround yourself with.
Exactly.
That's networking.
Exactly. And networking helps in finding jobs. People will tell you about job opportunities that are available, and even networking with people who don't live near you, because today in COVID's world, more and more facilities have gotten now used to having remote jobs. Not every job is remote, but we have a lot more remote jobs. I have a friend, it's funny, I have a friend in Salt Lake City, Nancy Reading. I have known Nancy since 1998. I met her on a listserv, and she and I have gotten to be very close friends. I've stayed at her house, very close friends. She just recently sent me an email telling me she lives in Salt Lake City. she's working for Hackensack University Medical Center, which is by me in New Jersey, as their education person.
Yeah.
Just because you live where you live, it does not prevent you from getting a job somewhere else.
Not now.
Exactly. I said, and why didn't I get to interview with Hackensack?
Yeah. You couldn't have said that 5 years ago. I do some little side work with SUNY downstate in New York, and that's great to be able to connect with those people, right? And not only the professionals that are also educators there, but also the students, because the students that ask me questions, they are driven, and so that's kind of fun and exciting.
It's so nice to teach, especially medical students, before they're getting out in the real world.
Yeah, that's right.
You see that medical coding, they learned from their teaching physicians who weren't doing it right.
Yeah.
So the people who weren't doing it right were teaching them.
Yeah, exactly.
When we can teach residents and medical students the right way to do things.
That's one of my passions. That's one of the things. That's one of my goals, future goals, is to be able to be involved in the medical student arena to get them prepped for. I mean, it's one thing to be able to do the procedure. It's another to get reimbursement for it properly, for the work you're doing. And so I want to get in there and teach them that stuff.
And compliant documentation.
And compliance, you're right. Exactly. Yeah.
And
because they aren't taught that. And when they get out, they're just kind of dumped, and said, okay, now start your practice, and, you're going to make money or not, So I think that would be kind of, and I know a few other people that are interested in that same area. So,
and as in networking, if you're first getting used to it and you're new, you have to be willing to ask for help and ask, does anybody know? And then as you start learning things, you have to be willing to reach out and pay it forward to other people. And although how I make money is for people to pay me for my knowledge.
Right.
But I am constantly giving my knowledge away.
Exactly.
Because that's the networking that I feel I have a debt to pay to all of my colleagues and even doctors, because I want to make sure people are doing it right. And I also know that if I tell people and help people, like I've just done today, when we're talking about 2021 guidelines and documenting right, you guys are going to think about me when you need somebody.
That's right. They're going to say, that Barbara.
I've often gotten consulting engagements from people who met me 10 years ago. I don't even remember it, because I network with so many people. Right. It's hard for me to remember every person I've talked to. And it used to be, yes, we networked. I've been networking online. Like, that's how I met Maureen. Even though Maureen lived an hour from me, we actually met on a listserv. Back in the day, in the 90s and early 2000s, it wasn't Facebook or LinkedIn. It was listservs. Now, it's Facebook.
Even 10 years ago, you couldn't do the networking. You had to do face-to-face networking, right? Or physically call people. So you had to rely on conferences, meetings, and everything. But now the world is literally open to you to network.
It's at our feet. We on Facebook, there are groups that are oriented. Not only are there groups for AAPC and AMBA and things like that, but there are groups that are specialty specific. For example,
at JFMAC, I love them.
I'm active in a group for otolaryngology coders. That's we're just that specialty.
Yeah.
LinkedIn, the same thing. We don't talk about politics and we don't put pictures of a family reunion. This is even though it's Facebook, it is very specific work related stuff. Yeah. And we network, and it's unbelievable. I mean, Lori, how I met Lori is on Facebook through CCO. I don't think I've ever met Lori face to face, but she and I are besties,
Yeah.
It's
yeah. That's how we found Lori, because she was prolific on the CCO stuff, and then Lori finally said, we got to hire that girl.
and I'm always trying to and again, this is how people know that I'm a resource. When I find out information, I stay on top of what CMS is releasing. So, for
Mhm.
example, CMS released the final rule for the physician fee schedule for 2021 on
Yeah.
Tuesday. On Tuesday, I was
On
in all
Tuesday.
my Facebook groups and on LinkedIn posting that information for people.
Yeah.
And
Yep.
then as I'm reading it, 2,100 pages, I found things that were like different and unique and things that I was not expecting. I wrote a blog because
Mhm.
CMS actually created their own G code for prolonged services.
Yeah.
And
And
so
we
I
talked about that a little bit before, but we're going to put up also that resource for our CCO club, the article that Barb wrote on that recently. I know that Lori took it and she let us know about it. And I think she put it on our LinkedIn, our Facebook, and stuff like that. But we'll make sure we get that to you too. Hey,
someone mentioned about networking, about home.
yeah, Jane.
There's a really there's a really neat group on Facebook is Jobs for American Medical Coders.
Yeah, that's how Barb and we're in a little side group for them. That's where we get in there and chat. So
you
yeah.
you might want to join
Mhm.
Jobs for American
Medical coders. Yeah, it's JF.
JFMC.
Yeah. We'll get that link to you guys.
Yeah,
Yeah.
and they have their main Facebook group is about job postings, and
Mm-hmm.
there are job postings that say they are remote, they're for home base,
Yes. Yeah.
but some may say they want 3 years or 5 years experience, but I have seen some that are posted that say CPC-A with no
Yeah.
experience is fine.
And you know what? Go back to our CCO live video that we did with two different people, Project Resume. I would check them out. And also, we did one with Lori's going to have to help me with his name, but a recruiter, to let you know, because they will help you get those jobs because that's their networking niche. I'm going to jump us into the next.
JFAM is coming out with a new product. I can't tell you about it because it's still it's in beta testing right now, but it's going to become. This is why you want to be on the JFAM Facebook groups. It's coming out and it's going to be very good for getting yourself out there for the recruiters to see you.
That's great.
Can't tell you about it.
He said it was Bertram. Yeah. Bertram. I don't know if you know him or not, but he was one of the recruiters. Let's jump in. We've been kind of talking about this, but for 2021, what are the go-to resources that you think people in the billing and coding that they need to have?
Well, I got to tell you, my biggest friend is Google.
Me too. How do you people ask a question and I want to say, did you Google it? Because I'm going to go Google it and, to answer you probably.
Exactly. And it's amazing what you can find. The things that I'm looking for on CMS, I just Google it. Okay.
Yep. It's straight to the area you need to go to.
There are even things that I found on CMS and I bookmark it, but it's still easier to go to Google and find it again.
I know, me too.
So Google is my best friend. I am a big user of Codify, which is AAPC Coder and Supercoder have been merged into one product, and it's called Codify.
Yeah.
And so that's the encoder that's offered by AAPC.
And I use FAC Find a Code, and they we talk about them all the time, but they have those resources. Yeah. Most encoder organizations, they have those resources. Right. And just a ruthless little plug that if you use this link, then you get 5% off your purchases with Find a Code.
So, but I'm saying I have been using Supercoder for years. I mean, since
Supercoder has been around for a long time.
I was a beta tester on Supercoder.
Yeah.
But then now they have forced me into Codify. What I use now. Another product that I don't think I could live without is a product called Swift Audit.
I think I know that.
Yeah, well, actually, through JFAM, you can get first of all, I think you get like a 3-month trial, and you get a discount on it. So
Okay.
we'll have to, you and I have to ask Leslie, and you can post the link through
Okay.
Sam for getting the discount.
Okay, good, good.
What Swift Audit is a product for auditing anything. It's set up to audit your E&Ms, and they have added the 2021 E&M for it. And for 97, it's got all of your different 97 exam guidelines, or you can pick your 95 body areas and organ systems. And you can also use it, but don't go there. Don't go to just swiftaudit.com. Wait till Alicia posts the link we have, because I believe that Jobs for American Medical Coders
we'll get the
both
discount.
A free trial and a discount for you.
Good.
But it also, you also can set it up and you can create your own checklists. So like I've created checklists for all the different age preventative care services. And so I can audit all the different preventative cares, making sure all the different areas of counseling have been done. So I can audit those type of services. If you're auditing a surgery, you can create a checklist, making sure that the signatures are there and all the things that you want to audit in a surgery. And what I love about it and what makes it easier is when you're doing auditing, you actually spend more time putting your results into your spreadsheet.
Yeah, you're right.
When you're done auditing in Swift Audit, it exports into a spreadsheet.
Wow.
Including your comments.
That's great, because that's exactly what you're going to pass on, and it makes you look more professional. Hey, we're right there on the hour. We wanted to let you know a heads up that there's these 6 new diagnosis codes that just dropped. They're pertinent to COVID, and there is some discussion about them not being in the manuals, and are we going to be tested on them and stuff. So we're going to definitely talk about this more, but this is the 6 codes in question. So again, pay attention to the CCO.us, and maybe if you're on YouTube or Facebook, you want to hit the little bell or whatever to remind you whenever we do a lecture, when a webinar pops up, so that you won't forget. Don't forget to like and subscribe, all that good stuff with us. If you guys enjoyed tonight, then by you going in and hitting that like button, that lets us know that we're producing content that is applicable and helpful to you. And we're going to put up.
I really like the personal history of COVID. We haven't had that. And
you know what? That's what my sister dealt with, because she went in to the ER. We were just talking about that, and she'd quarantined, and she was like 2 weeks out of her quarantine, but she had gotten pneumonia, and so she was still having problems. She ended up in the ER, and she said, "What do you code for a person who I don't have COVID anymore? However, I did have COVID, and that's why I've got these problems." And
there's long-term effects of COVID. I'm talking about 6 months. Problems.
They think that it affected her heart, and so she's got to go off to a cardiologist. And we're just now learning that type of thing. Thus, they're dropping new codes that are applicable. Unlike ever before, in the history of us as coders, have we had codes being dropped like the vaping, and the vaping wouldn't have dropped if they hadn't already decided, if COVID had not have happened. I'm sure it would have just waited for the next year, but they went ahead and put those together. And this is really, it's nothing like a pandemic to change everything. So we're going to give you more information on these codes in the very near future. So stay tuned for that. And I think that wraps us up with 1 minute to go. And you know what? Isn't it fun, Barb? What I would like to ask Barb, just real quick, and you got like 30 seconds to do it. I always come up with some really weird question to ask. So, Barb, if you could travel to any country in the world outside of the United States or territories, all expenses paid, and you could stay a week, where would you choose? Where would you choose to go?
To Bali, with one of those, huts that's over the water.
Wow.
That's sort of like
Yeah.
my dream vacation.
To go to Bali. Oh, wow.
Well, actually, and they have, I think now in Costa Rica, they have them too, where they have like, just my husband and me in this hut
Yeah.
that's alone over the water. And,
Yeah.
I love vacations that are at the beach, at water, that are warm. I live in New Jersey. Actually,
You want warmth.
I live at the shore, but I never go to the Jersey Shore. I live 7 miles from the beach, but I just love a beach type vacation. But I've
You're a
always
water baby.
dreamed about that kind of vacation. Believe it or not, I have traveled all the way to the Philippines.
Oh,
I
nice.
have traveled far. Yeah, a company brought me out there to see their operation because they wanted to be able to get billing and coding business, and they wanted to show me how they were doing things that were HIPAA safe.
Right.
And so I was out there and I was very impressed. People at this company aren't allowed to bring any of their personal belongings inside the work area. They work on multiple monitors. They do not have
Yep.
pen and paper. They do not have any personal belongings. So there's no way for them to bring any information out of the office. They have
Mm,
lockers outside of the work area where they have to lock up their purse and everything in their pockets. And then
that's
go in there empty, and they
so
can't.
you were
Yeah,
able to go out and kind of vet their process. So
yeah, yeah.
that's great. Um, you know what? Thanks, Barbara. We had a lot of fun. We'll have to do
Yeah.
this again in the future. And if there's anybody that you guys would like to have us on a CCO live, these casual conversations and kind of just have fun, let us know, and we'll see about getting them on. We really appreciate Barbara making time for us. And if you want more information about her, you can get the link. And of course, the CCO Club will give you additional information. Go to cco.us/club, and you'll get all of the background, the resources that we talked about, links, as well as the transcript, the recording, and the slide deck for tonight.
And guys,
So
I tell you, I always, if anyone ever asks me where can they learn anything that's coding, billing, management, anything related to our industry, I always send them to CCO.
thank you. So she vetted us.
Oh,
Yeah.
I have known Lorene. I taught Lorene E&M.
Yeah, I remember her talking about that.
Before she even knew E&M. I can say that.
Yeah. Yeah. Okay, so we'll wrap up. Thank you guys for staying with us and joining us. Don't forget to like and subscribe. Tell others. We don't advertise, so feel free to share on LinkedIn and all those other great social medias. That if you think that content like this and the other content that we put out every week, at least 2 webinars live every week, then share and tell your friends. All right. Thanks, guys.
Thanks,
Bye.
guys.